Colorectal cancer is one of the most common cancers worldwide, and understanding factors that affect patient outcomes is crucial. Recently, researchers have turned their attention to myosteatosis, which refers to the infiltration of fat within skeletal muscle. Unlike sarcopenia, which is simply a loss of muscle mass, myosteatosis involves changes in muscle quality and is thought to impact both recovery after surgery and long-term survival. In this video, we'll explore how myosteatosis is defined, how it's measured, and what the latest research reveals about its influence on postoperative complications and survival in colorectal cancer patients. Myosteatosis is typically assessed using computed tomography, CT scans performed before surgery. The most common measurement is skeletal muscle radiodensity, or SMD, which evaluates the average density of muscle tissue at specific locations, usually at the third lumbar vertebra L3. Different studies use various cutoff values to define myosteatosis, such as Martin's or Zio's definitions, which take into account factors like BMI, sex, and age. Some researchers also analyze the psoas muscle or use ratios like IMAT and IMAC to quantify fat infiltration. This diversity in measurement methods has led to some challenges in comparing results across studies. Recent systematic review analyzed 54 observational studies from around the world, focusing on both non-metastatic and metastatic colorectal cancer patients. The studies included a mix of prospective and retrospective designs, with patient ages ranging from 40 to over 80. Researchers extracted detailed information about patient characteristics, treatments, and surgical procedures, as well as how myosteatosis was measured and defined. Importantly, only studies with a sample size greater than 50 were included to ensure robust findings. The review followed rigorous guidelines to minimize bias and ensure the quality of evidence. One of the main questions was whether myosteatosis increases the risk of complications after colorectal cancer surgery. The evidence here is mixed. Some studies found a significant link between myosteatosis and overall postoperative complications, while others did not. However, when focusing on severe complications, those classified as Clavien-Dindo grade 3 or higher, the association was more consistent, especially in colon cancer patients. This suggests that myosteatosis may be a useful marker for identifying patients at higher risk of serious surgical complications, though more research is needed for rectal cancer specifically. Another important outcome is the length of hospital stay after surgery. Several studies investigated whether myosteatosis leads to longer recovery times. Some high-quality studies did find that patients with myosteatosis stayed in the hospital longer, with differences of about 1 day on average. However, not all studies agreed, and the clinical significance of this difference remains uncertain. The evidence is stronger for colon cancer than for rectal cancer, but overall, the impact of myosteatosis on length of stay is still being debated. Perhaps the most critical question is whether myosteatosis affects long-term survival. Across 23 studies, most found that patients with myosteatosis had worse overall survival, especially in colon cancer. The hazard ratios range from about 1.5 to 2.4, indicating a significant increase in risk. The association was less consistent in rectal cancer, possibly due to differences in treatment approaches. Some studies also found links between myosteatosis and cancer-specific survival or disease-free survival, but these results were less robust. Overall, myosteatosis appears to be a negative prognostic factor, particularly for colon cancer. Despite these findings, the overall quality of evidence is considered low to moderate. Many studies were retrospective and varied widely in how they defined and measured myosteatosis. There was also inconsistency in adjusting for confounding factors like age, sex, BMI, and treatment regimens. Only 16 out of 54 studies were rated as good quality. This heterogeneity makes it difficult to draw firm conclusions and highlights the need for more standardized research methods in the future. Looking ahead, researchers recommend standardizing CT scan protocols, measurement techniques, and diagnostic thresholds for myosteatosis. It's also important to analyze colon and rectal cancer separately, given their different treatment pathways. Large, prospective studies with robust adjustment for confounders are needed to clarify the true prognostic value of myosteatosis. Only with more consistent methods and reporting can we fully understand how muscle quality impacts outcomes in colorectal cancer. Summary: myosteatosis is emerging as an important factor in colorectal cancer care. It's associated with worse survival and more severe postoperative complications, especially in colon cancer. However, the evidence is limited by variability in measurement and study design. As research continues, clinicians may one day use myosteatosis as part of a precision medicine approach to better predict risks and tailor treatments for individual patients. For now, awareness of muscle quality remains a valuable consideration in the management of colorectal cancer.